Good afternoon, ladies and gentlemen, or good evening, almost. I'm here to present to you our company, NovaHep, our fantastic technology and our great perspectives. We're a private company. We're based here in Gothenburg, not far from here at the biotech house. So our area of work, what is that? It's advanced regenerative medicine, as we call it. So we're developing unique, individualized organs for transplantation. This is something we see as the future. This is the next generation of personalized medicine. So we're tissue engineering fully biocompatible organs. So with stem cell technology, we're able to go from something allogeneic to something autologous, from something foreign to something rather being personalized, individualized, or customized, you might say. So the key words to note here in the beginning are those of decellularization and recellularization, respectively. Tissue-engineered vessels for life, as we say. It might all sound a bit science fiction-like at this stage, so you may want to ask, what's the technology behind? What's the trick to this? And let me kick this off by starting to say that our technology relies on the amazing work that's been done by Professor Suchitra Holgersson here at University of Gothenburg. Suchitra being one of the co-founders of NovaHep. And in essence, what this technology does is that it strips a donated tissue or a donated organ from all its cells, and subsequently it reseeds this same organ or tissue with stem cells of the patient who is to receive this organ or tissue in a transplantation. And this technology is basically applicable to any organ. Take a heart. Here we have a donated human heart. So what we do is that we, so to speak, decellularize it. So we take away all cells, all DNA of the donor. And the good news is that the heart doesn't disappear by doing so. The three-dimensional structure, which makes up the heart, the scaffold, remains very much intact as an extracellular matrix, I should say. What we then do is that we recellularize the scaffold. So we seed onto this scaffold stem cells from the patient, as I mentioned before, who is to receive this heart, in this case, in a transplantation. So we basically grow a new heart that's fully biocompatible with the patient who is to receive it. I mean, dwell a bit maybe at this and imagine what a game changer this is, what an impact this will have. This brings me to the question, obviously, of whether there is a medical need for this. And the answer is a clear yes, obviously. Why? Well, consider the shortcomings and drawbacks of transplantations today. There's a lack of suitable donor material. There are severe side effects associated with lifelong immunosuppressive treatment. And there's oftentimes the need for repeated surgery. And with our technology, we're addressing these shortcomings and drawbacks, and we want to overcome these shortcomings and drawbacks. So basically, what we want to do is that we want to provide for improved global health. We want to provide for increased, or improved, I should say, quality of life for patients. And we want to provide for cost-effective care for hospitals, healthcare providers, and society globally. So our technology has really the potential for tissue engineering a full range of biocompatible organs and tissues. Now, realizing this great potential is and will continue to be a step-by-step process, obviously. So before we're able to offer, so to speak, fully biocompatible whole organs, we've settled on an initial focus being blood vessels. So we want to commercialize and utilize this technology now. We want to target a quick market access with a unique first product offering, a unique first product family. And that first product family within blood vessels is that of veins. And within veins, or I should say the first indication that we will be targeting is the indication chronic venous insufficiency, or CVI, which is a condition by which the valves of the deep veins of the leg aren't functioning properly. They're not opening and closing as they should, they're damaged, typically following a previous case of thrombosis. Now this has severe burdens and pains for the patient suffering of this condition. It's associated with swellings, it's associated in some instances with nasty ulcers around the ankles. And for these patients today there is no curative treatment. So patients are treated symptomatically, given temporary relief by being handed stockings, ointments, bandages, and so on. So what's really needed here is exactly what we can provide. A tissue-engineered vein with functional valves, the PTEV, as we call it, which is then set to replace the part of the vein in the leg which contains these damaged valves. In itself, this indication being just one between or amongst many that we could target with our veins, this indication itself represents a great commercial potential, a great market potential. And for the sake of time, I'm not going to go into the full process of how to and recellularize our veins, but just want to give you the most compelling messages, and that is that the recellularization, the personalization of the vein that we're sourcing from a donor, this personalization process is something that can be done in 1 week only. It requires no expansion of stem cells, but rather relies on perfusion with the patient's own blood. 25 milliliters is all that's needed for this. So how far have we come? Preclinically, we've shown proof of concept, and recellularization for a number of organs and tissues. But where we've come the farthest is really with veins, where we've even seen proof of concept in humans. So about 3 years ago, in 2011 and 2012, 3 patients were transplanted with engineered veins, tissue-engineered veins that were developed with the NovaHep technology. 3 children suffering from thromboticized portal veins. And transplantations were carried out for the first time ever in history here at the Sahlgrenska Hospital by Mikael Olausson. And no immunosuppressives were used here. And at 2 and 3 year follow-ups, there's been no sign of any immune reaction, and there's been no sign of any need for additional surgery. So this is really a great story, a great proof of concept, an in vivo proof of concept, I should say. So not just preclinical. One of the patients, the first patient, was a 10-year-old girl. She had part of her portal vein leading blood from the intestines to the liver. She had a part of that replaced with a vein shunt that was engineered with the NovaHep technology. And what happened after that? Well, her physiological development picked up. She's doing better in school. She's experiencing a much improved quality of life. So that's obviously fantastic for us. I want to say that the solutions that we're providing will be superior, in our view, to any synthetic or any semi-biological products, as these are truly and fully biocompatible. Many others, or some others, are able to decellularize certain organs, tissues, but what is unique, proprietary, and patent protected for NovaHep is the recellularization part of these blood vessels to start with. That's the truly unique part, and that's what we're mastering at NovaHep. Competition-wise, for the CVI indication, well, there is no competition. No vein graft on the market contains functional valves, synthetic or non-synthetic. So that's a good environment to be in. I'm running out of time. The business model, I'm not going to go into too great detail about that. Just want to mention that we have one, which is well developed and defined and in place to reap the commercial potential with this technology. I'm obviously happy to discuss this in much greater detail should you be interested later on or if you get in touch. What I want to mention at the end here is the track that we're on, the route we're taking. We're focused on a 2-year project plan now. It might sound aggressive, but we're targeting a market access, a first market access in 2 years already. We're on a fast track regulatory-wise, so our product, which we see will be treated as an ATMP, an advanced therapeutic medicinal product, with the possibility for an adaptive licensing, where we do a limited first clinical trial, we then get a limited market access, and from there on we expand. So the first clinical trial is planned to take place at Oslo University Hospital and set to commence in October of this year. And what will else happen in this 2-year window? Well, we will obviously be expanding, building up our organization even further. And we will, before this clinical trial, see GMP adaptation of the processes and material used for developing our PTEF, the personalized tissue engineered vein for the CVI indication. Obviously, to go through these steps, we need financing. And so we're currently raising capital, and we're still very much open to discuss, obviously, with any interested parties. So with that, I want to thank you for your attention.